Good evening, everybody.
Good afternoon.
Good afternoon. My name is Jennifer Falk. I am the MS Social Work Navigator for MS Views and News. I am a social worker. I have my master's degree in social work, and I've chosen to make my practice and my focus of my work to be with the MS community. That means a lot to me, and I'm very happy to be able to work with the MS community. I'm very happy to be here. I arrived here this morning from Miami, so we're very excited. MS Views and News is growing. We're doing many programs in many different locations. We're very happy to see you guys here today. How many of you, is it your first MS Views and News program? Have any? Okay, we got a couple. Well, welcome. And for everyone that's come back, it's great to see you again. So we're really happy that you're here. We feel very strongly that education and information and knowledge brings to you empowerment, and that's the most important thing, that you guys live the best quality of life and you live in wellness, and you're doing great. So we're really happy to bring this program to you. We want to thank tonight Teva Pharmaceuticals. Without Teva, this could not be possible. They sponsor this program, and they make programs like this possible for us to bring to you. So thank you to Teva. And I also wanted to point out to you before we get started, if any of you don't go on our website, we have a MS Views and News Learning channel. And the reason Bill is recording this tonight is so that not only you guys can learn from it, but so that we can air this for thousands and thousands of people that log on to our learning channel and watch programs like this one tonight. So if there's a topic that comes up for you, or you know someone that has questions and wants to learn more from an MS expert, if you look at this YouTube button right here, where it's blue, thank you, Bill, he's putting the pointer on it, that's on the cover page of our website. And you will hear specialists, MS specialists, neurologists, neuropsychologists, social workers, psychologists, neuro-ophthalmologists, all speaking about specific MS issues that you can learn from. And you can also share this with your family, with your friends, so they can have a deeper understanding of what this is, the mechanisms, how it works, and how they can learn more about it with you. So here you could see, these are all of our speakers, these are all of our programs, so it's a really wonderful resource for you guys to be able to use. Okay, so tonight we have a little change in the schedule. We have Dr. Buckle here. Dr. Buckle is here from the MS Institute at Shepherd Center, and he's going to speak to you on current MS treatments and MS relapse. And then after that, we had Dr. Godsoul, who was scheduled to speak also, but unfortunately he's really under the weather. So our thoughts go out to him that he recovers soon. And instead, I'm going to speak with you tonight and give you some good social work presentation on cognition and coping with that. So absolutely. So let's welcome Dr. Buckle. Thank you.
The topic I was asked to talk about tonight was treatments, so it'll be a fairly general topic. We'll do a little bit about what causes MS so that we can understand the treatments a little bit better, and some of the things that you can do even short of taking the prescribed treatments to help keep your MS from getting worse. And I'm going to try and keep it to about 40 minutes or so, and then we'll have plenty of time for questions. So I see some familiar faces, which is always good. And then I see a lot of unfamiliar faces, which is even better. So it's always good to have new people and new speakers and so forth. So, all right, with that, I'll get started. So I'm at the Shepherd Center. I've been there about 1.5 years. I know a few of you from there, and some of you probably might see Dr. Thrower or Dr. Loring as well. If you don't know the Shepherd Center, we're a large inpatient rehabilitation center which started for spinal cord injury and brain injury, about 150 inpatient beds. And then the outpatient services are MS, chronic pain, and then we have a multi-specialty clinic that does urology and spasticity and all of the severe symptom management for MS as well. So we have all of the available rehabilitation facilities and so forth. So it's a really unique place. We have a lot of ongoing programs that you don't find anywhere else, including MS wellness programs, day program where you come and stay for 2 weeks and get your MS tuned up, get the best of the physical therapy, occupational therapy, speech therapy, exercise physiology, anything you need. Okay, I think we're working again. So unfortunately the slides are cut off at the top here, but I think you can see on the monitors they're a little bit better. So we'll start with the usual introductory slides that you guys know already. So MS affects only the central nervous system, so that means the brain, the spinal cord, and the optic nerves. It does not affect the so-called peripheral nervous system, so once the nerves get out of the spinal cord and go out into the arms and legs and so forth, it's different. For some reason, MS doesn't affect those nerves. There are other things that do affect those nerves, neuropathies and things like that, but not MS for some reason. So for MS to get started, cells have to get into the central nervous system, and when that happens, the classic view of MS is that it's an autoimmune disease, which means that your body is reacting against something, some normal tissue in your body, and creating an inflammatory response which shouldn't be there. So it recognizes a normal tissue as somehow being abnormal, and it mounts an inflammatory response. We'll talk a little bit more about inflammation, and I'll show you some examples of that. What that means in terms of symptoms and so forth is when this myelin, the insulation or the coating on the nerve cells, breaks down, and the nerve cells don't conduct as well. It's like nerve cells are almost like wires. They don't conduct as fast as electricity, but they're like wires in the sense that they're long, thin cells that conduct an impulse, and they're surrounded by insulation. So the myelin is the insulation. When the myelin gets damaged, the wire doesn't conduct as fast. It's like a short circuit. And if the axon, the nerve cell itself, gets transected or broken, then no signal gets through at all. So that's like the wire has been cut. And we realize now that it's very common to see significant damage in MS lesions or plaques or whatever you want to call them. It all means the same thing. It's not just the myelin that's destroyed, which is the classic view, but that the axons get cut often early on in MS as well. So we like to get people started on treatment as early as possible to prevent this, and I'll show you some data and some microscope slides looking at that specifically. So the destruction of the myelin results in these plaques, which we can see on the MRI scan, and often in symptoms, typically acute relapses. And then there may be periods where there's no activity, no inflammation, and no new symptoms, but over time, MS can go into this progressive phase where it continues to get worse, even in the absence of relapses. And that's what we ultimately want to prevent. Because once MS gets into this progressive phase, it's very difficult to treat. We've only had treatments available, FDA-approved treatments, for about 20 years now. So we're seeing a lot less progressive MS, but that's only because we're treating it earlier and preventing it from getting there. So the treatments work on the relapsing remitting phase of MS. We'll talk about that a little bit more. So here's an animation of that. So this is the nerve cell coming through here. It's covered by the myelin. You see the nerve cell in the middle, and you have these little interruptions in the myelin along the way, and the signal jumps from one to the other. Now in MS, T cells come in, they attack the myelin, and they do it by secreting proteins called cytokines, which damage the myelin. As you can see here, they don't always damage it all the way, and if the damage is mild, the myelin can actually grow back. So there is a drug in development now called anti-LINGO, which is an antibody that promotes remyelination, so that actually promotes the cells, the oligodendrocytes that make the myelin to have the myelin grow back. So we had some very promising results, preliminary results in that, looking at patients who'd had optic neuritis, which is inflammation in the optic nerve, and the patients who received this drug actually had what looks like some regrowth of the myelin, some remyelination in the optic nerve. They actually got better in terms of their recovery if they were on the drug. Now, if the inflammation is really severe, you can get what's called axonal transection, which means the nerve is actually cut. So these same cells and protein cytokines come in. They not only cause the demyelination, the damage to the insulation, but they can actually cause the axon to be transected or cut. And unfortunately, once that happens, there's nothing we can do. There's no treatment or anything that will regenerate that axon, with the possible exception of stem cells. So stem cells at least have the potential to regenerate neurons or axons, but right now they're still very much in the experimental phase. So most of our drugs are directed at preventing inflammation. We'll talk a little bit more about inflammation. Inflammation is what causes the demyelination, and if it's bad enough, it causes this transection. So by preventing the inflammation, ultimately, we're trying to protect the neurons from being destroyed like this. So here is an actual microscopic slide. This is a very famous study done at the Cleveland Clinic by Bruce Trapp, who is a pathologist there. And this is, instead of looking at a cartoon picture, this is looking at a real picture. So there are 3 axons coming through here from right to left or left to right. You can't really tell which way the signal's going by looking at it like this. When you look at this one, you can see the green is the axon itself. The reddish color is the myelin, and then where the myelin is normal, the 2 colors merge and you get a yellow color. So these are actual axons in an MS lesion or plaque that have been stained with 3 different antibodies to produce these colors. So this axon is intact, as you can still see. The myelin is not great, but it's pretty good. There's a little bit of loss here. If you look at this one, the axon's still intact, but there are areas where the myelin has been stripped off, so we would call that demyelination, but the axon is still okay. In this one, the axon's been transected or cut, and when that happens, it rolls up into a little ball like this, and it starts dying off, and it dies back this way, and eventually that cell will die. So there's nothing we can do once it gets to here, and when you look at old chronic plaques of MS, you see lots of these. So lots of these lesions in the white matter of acute MS, and even more if you look in the white matter of chronic MS. If you look at the brain itself, this is an actual section of a brain. So on these, the white matter looks white, as you can see in the middle here, and then this is the gray matter. Gray matter in a brain at autopsy like this actually looks kind of brownish. Gray is a little bit of a misnomer, but it's darker than the white matter, as you can see. And then you see this big area here. That's a plaque, an MS plaque. Does anybody know what this is? So this is the ventricle. So the ventricle is where the spinal fluid is made. When we do a spinal tap, we can get at the fluid in your lower back with a needle in the back, because the spinal fluid then goes down and circulates around the spinal cord. But what we're looking for is inflammation up here in the spinal fluid, right around the ventricles. So this would be a very typical place to see MS. And when you feel these lesions, when you actually touch them, they're very hard. So that's where sclerosis comes from. Sclerosis means hardening. So multiple means multiple, obviously. There are lots of them, or many of them at least, and they're hardening. So before they had microscopes and things, this is all they could look at, was the brains of people who, at autopsy, who had died from multiple sclerosis or various other diseases, and this was the initial finding. Now we have MRI, so we can see these lesions on the MRI scan. So I told you they often line up around the ventricles. So on this scan, the patient is lying on her back and she's looking up. Her eyes would be up here. These blacker spaces are the ventricles. Now we flipped it around so the white matter looks dark, and the lesions, the plaques of the MS, stand out white. So you can see them around the ventricles on this. This is a T2 weighted scan. This is called a flare scan. Now she's facing that way, and you can see how they come right down to the ventricles like that. And similarly on this scan, that's also a flare scan. So I know you can't read the dark type here, but it doesn't matter. These are just some examples of typical MS lesions on T2 weighted and flare scans, MRI scans. Has everybody seen their MRI? Anybody who has MS? Yeah. If you haven't, you should ask to. It's always a good thing to see. You should always be able to see your MRI, ideally, each time you have it. If it's completely unchanged from the previous one, you probably don't need to, but if you have new spots on the scan, you might want to get an idea of where they are and what they look like. You're not going to remember the next time, but you want to get some idea of how many you have or if they're increasing over time. So we do MRI scans basically every year on everybody, even if they're doing well and they're taking their treatment and they're not having any new symptoms, because things can happen on the MRI scan with no new symptoms. So you can have new spots on the MRI scan even without a relapse. In fact, that's fairly common. For every new relapse, and we'll talk a little bit more about relapses next, in the old days, before there were any treatments, there could be up to 5 new spots on the MRI scan. So we found that the MRI scan was very sensitive for looking at MS. It was more sensitive than actually the relapses. The other thing we found when we give the gadolinium injection, what we see here is sometimes if the MS is active, some of these spots light up. So they don't all light up at the same time, and that's shown, well, this is, I'll go to this one first. So if you look at this, here's a spot, a periventricular lesion right against the lesion. Here's another one up here, but then you give the contrast injection, and only this one lights up, right? So this one doesn't, and there's another little tiny one over here. That one doesn't either. So the ones that light up after the contrast injection are the ones that are active. But that activity only lasts about 3 weeks or so. So if we see activity like this after the contrast injection, we know that the MS is active right then and there. If we see only spots like this on the flare, slides just went off. Then we don't know if that MS has been active unless we have a previous MRI to compare it to. So we like to get an MRI typically every year. We might have to do it even more often if somebody's having new symptoms. And then here are some other examples of how these lesions look. Now some of these slides are more for the residents and fellows, and so some are a little bit high level, so you wouldn't necessarily know what you're looking at here. But just to explain it to you, this is a blood vessel, so this is a vein in the brain, and in order for the cells to get out and cause damage in the brain, they have to get out of the blood vessel. So each one of these little black, round, ovoid things is a cell, a lymphocyte. A lot of them are T cells, B cells, other types of lymphocytes. And then they had to get out of this blood vessel and crawl out into the brain to cause damage. Normally you should not see this. Cells do not get out of the blood vessel and into the brain normally. So that's the key pathology of MS. As we see inflammation, these cells that are supposed to stay in the blood vessel somehow get out of the blood vessel. They cross what's called the blood-brain barrier. So the blood-brain barrier is supposed to keep the lymphocytes and other cells in the blood. If it gets broken or compromised, then they can get out into the brain or the spinal cord and cause inflammation. All right, so any questions on that? So we still don't know exactly what causes MS. We have a lot of theories. We know that MS is common in young adults. We'll get a little bit more on the age of onset, but it's typically between 20 and 50. It doesn't mean that we don't see people being diagnosed with MS when they're over 50 years old, but very often, if you go back into the history or talk to them or they think about it carefully, there might have been something when they were younger that they didn't think of much of, some blurred vision in one eye or double vision that didn't last long or some numbness or tingling or something like that. Or they've just had this overwhelming fatigue that's been unexplained for years, and that's very common. There are about 500,000 cases in the U.S., about 2.5 million around the world. And overall, the chances of getting MS anywhere in the world, or at least in North America, is about 1 in 1,000, all things considered. And we'll talk some more about some of these other risk factors. So here's the typical age of onset. So these would be pediatric MS cases, 11 to 20, so people in their late teens, early 20s, 30s, and so forth. So as you guys all know, this is a disease that unfortunately starts early in life very often when people are in their peak productive years, they're starting families, working jobs, have careers, and so forth. And this can be, in the old days, this was a devastating diagnosis because we had no treatments. And when we looked at the older literature, the older studies, most people ended up being significantly disabled within about 20 years of the disease onset. So that's all changed now that we have treatments, disease-modifying therapies, which we'll talk about in just a few minutes, what's available. And then as you can see, later on into the 50s and 60s, it's rare to have MS start that late in life, although sometimes we do see patients coming in with an abnormal MRI scan in later life, which is done for some other reason, and they have spots that look like MS and they never knew they even had it. And that's becoming increasingly common as more MRIs are done for various reasons, headache or motor vehicle accident or whatever it is. This is MS around the world, so some of the highest incidence or prevalence of MS is in North America and in Northern Europe. This is Iceland, that has a high prevalence. Where it's white, we don't really know very well, and in the large parts of the Soviet Union and China, we don't know too well as well. But as you get further away from the equator, the incidence of MS goes up, i.e. it becomes more common, and we see that both in the Northern Hemisphere and in the Southern Hemisphere if you look in Australia, where that's pretty well documented as well. So what do we think it is? This is an example of the UV index. So this is ultraviolet light. You can see it's very high at the equator, and as you go away from the equator, the ultraviolet light goes down. So we think that this has something to do with vitamin D levels. If you haven't had your vitamin D level checked, you want to get it checked, because the lower the vitamin D level, the higher the likelihood that your MS can become active. So even if you're not on a disease-modifying therapy, it's a good idea to supplement your vitamin D. If you don't know what the level is, it's just a blood test. Your primary care doctor or your neurologist or anyone can do it. You want to, as you can see, it's probably hard to read the numbers here, but the basic idea of this graph is that here are the higher levels of vitamin D, and the higher the level of vitamin D in the blood, the less likely you are to have activity on your MRI scan. So these are people who are coming in having MRI scans on a regular basis once a month and getting their vitamin D levels checked as part of a study. So you don't want to go too high, but it's hard to go too high. The typical supplement's about 5,000 units once a day. That's pretty much safe for everyone. If your vitamin D is really low on the blood test, we typically give people 50,000 units once a week. And we do that for about 3 months, and then we recheck it. So that's something you can do to help prevent your MS from getting worse. Other things, as I said, we don't know actually what causes MS. We suspect there's a virus involved, but if there is, it's one that's very, very common, and unfortunately we can't do anything about. So here's a study looking at EBV, or Epstein-Barr virus, which is the virus that causes mononucleosis. So if you look over here, these are the cases, these are the people with MS, and virtually everybody with MS has antibodies against EBV. The problem is almost everybody who doesn't have MS has antibodies against EBV as well. So it's a very common virus. We all get exposed to it. Most people don't remember having mononucleosis, but some people who later develop MS will remember having a particularly bad case of mono in high school or something. And it's a very difficult thing to study because about 98% of the population has antibodies against EBV, although about 100% of MS patients have antibodies against it. What we need is an effective vaccine. If you look at all the studies that have ever looked at EBV and MS, not one of them was negative. So this line means there's no significant association. So that would be in epidemiological studies. Everything to the right, each one of these is a large multi-center study. Everything to the right of the line means that there's an association between EBV and MS, and everything to the left of the line would be negative association. So there's nothing to the left of the line. There's some studies that are right on the line, like this one, which would say there's no association between the two, but most of them show a positive association. So we think that there's a role for EBV in triggering MS, but unfortunately we don't have an EBV vaccine. So when people talk about curing MS, that would be potentially, if it turns out that EBV is involved, that would be a potential cure, right? So if we had a vaccine for EBV that was safe and effective, we could vaccinate a large group of children, follow them over the years like we do as they did with smallpox and polio, measles, and all these other childhood diseases, and then see if the vaccinated children as a group never came down with MS. That would be a great experiment to do, but we don't have an effective vaccine. There are a lot of people working on it. How about genetics? People ask me all the time, is MS a genetic disease? What's the risk to my child? Well, it's very small. So this is an older study. If MS were a purely genetic disease, then you would expect twins, identical twins, who have the exact same genes, after all they're identical. If one twin had MS, you would expect the other twin to have it too. So we would call that 100% concordance. So they both have MS or whatever else, whatever other genetic disease one of them might have. But in fact, it's only 25%. So there's clearly a genetic component. It's not a random thing, but it's not a 100% match. And if you go to a fraternal twin, so they share about half of the other twin's genes, that drops down to only about 5%. If you have a sibling with MS, it's about 3%, and so forth. And then your spouse, who's presumably sharing the same environment, has about the same risk as the general population of about 1 in 1,000 here. So there is a little bit of increased risk for a child. It's only about 2% increased risk, so it's pretty minimal. So MS has a genetic component to it, and there have been over 200 genes now identified as having a potential influence on MS, but I wouldn't say that it is a genetic disease. There's a genetic propensity to it, which may be triggered by this EBV, the Epstein-Barr virus. Other things you can do, short of taking medication, and which all of us should do, is stop smoking. So this is the increased likelihood of developing MS if you're a smoker. So the more you smoke, the more likely you are to develop MS. Not only that, but the earlier you start smoking, the more likely you are to develop MS. The more you smoke over your lifetime, the more likely you are. So the duration is there. If you quit, you go back down to the original risk over a matter of a few years. And if you have MS and you smoke, smoking makes your MS progress faster, so you'll get worse faster. So if lung cancer and emphysema and heart disease are not enough reasons to quit smoking, then if you have MS, this is one more. Okay, I'm not going to go too much more into that. All right, so we'll go on to a little bit about the diagnosis. You guys are probably familiar with this. Most MS starts as relapsing remitting, and then as I mentioned earlier, if we don't catch it in time, and in the old days before we had treatments, MS would become progressive, so the relapses would become less frequent, and over time the disability would continue to get worse. And then there are about 10% of patients that never have relapses. So there might be one person or two in this room that had primary progressive MS, where they just started out getting slowly, steadily weaker from the outset and never had a relapse. That's about 10% of cases. Okay, so here is the way we look at it now in terms of the onset of MS. There are various other stages here that we identify. So there's sort of a preclinical phase to MS. So what's happening here, this is meant to be time along the bottom line, and this is meant to be symptoms or disability here going vertically. So relapsing remitting MS is how MS typically starts. And the very first symptom is called CIS, or clinically isolated syndrome. All that means is the first attack of MS. But when people come in with clinically isolated syndrome, and that's often loss of vision in one eye, or double vision, or weakness, numbness, and coming from the spinal cord, something that actually causes symptoms. When we look at the MRI, which is meant, these little arrows are meant to represent, we already see spots on the MRI that they never knew they had, obviously, because they didn't have an MRI before. So there's a phase here where MS starts even before it causes any symptoms. And you can see it on the MRI scan when people come in with their first symptom. Now, as I mentioned, we're seeing people more frequently even who've never had a symptom, so they're way back here, and this is called radiologically isolated syndrome. They've never had a symptom at all, but they've got spots on their scan that look like MS. And if you follow those patients for a few years with MRI scans and following them clinically, about 2/3 of them will go on to develop MS. So there's a preclinical phase, which we're now seeing more off on the MRI alone. Then after the first relapse, we like to start people on treatment here. We used to wait for the second relapse. In the old days, it wasn't MS, or it wasn't relapsing remitting MS, until it had come back and started a new symptom somewhere else in the central nervous system. And we'll talk about the symptoms in the next couple of slides. As I said, if we didn't, before we had treatments, then this is the people over the course of about 20, 30 years will get into this secondary progressive phase. The relapses will become less frequent, the MRI wasn't as active, but the disability score continued to go up. And that's called secondary progressive MS. And we don't know what makes MS turn from relapsing remitting MS to secondary progressive MS. We don't know if it's some change in the immune system, or if the axons are just dying off at a faster rate, the nerve cells. We don't know what it is, but as you know, I'm sure this is the big unmet need in MS. We don't have a medication that is effective or as effective once MS is already in the progressive phase, either secondary or primary progressive MS. Okay, so let's talk a little bit about relapses. You guys are familiar with the symptoms of MS. You can go down the list, and these are the more common ones. If you look at them numerically, like how common, I'm sorry, the labels are down here. You can't see them very well, but what do you think this one is? That's 80% there, and in some studies 100%. Fatigue, you got it. So almost everybody has this fatigue, and we still don't know what causes the fatigue. We think it's something to do with the inflammation in the brain, but even when you completely shut down the inflammation with our best treatments, that fatigue is still there, isn't it? Every once in a while, people report a little bit of improvement in their fatigue when they get on treatment, but it almost never goes away. What's this one? It's kind of fun, actually, because you can't see it, so you have to guess. That's the bladder, I think. Hold on. Yes. Bladder problems. And then you can go down the list. Pain is in here, of course. Cognitive problems, weakness, numbness, etc. You guys know the symptoms. So there's often this confusion about, MS symptoms and MS relapses. So relapses mean new symptoms, right? So when somebody says they're having a relapse, what we're looking for, our chief concern is this the same symptom that's come back for some reason, or is it a new symptom? Can we map it to some new part of the brain or the spinal cord or the central nervous system to say that the MS is definitely active again? You all know that your symptoms will get worse if you get out in the heat, if you're stressed, tired, fatigued, etc. If they are gone again or back to the baseline, with a good night's sleep, and you come into the air conditioning, that's not a relapse. We call that a pseudo-relapse. Your symptoms just got worse because you were out in the heat or you had an infection or whatever it was. What we're worried about are new symptoms somewhere else that last. So the definition of a relapse usually includes that the symptoms last at least a day or two, preferably 2 days. So as you know, most of these things don't happen immediately. They come on over the course of a couple of days. So if you have a new symptom that lasts more than a day, you need to tell us, especially if it lasts more than 2 days, and you'd be surprised. They've done studies where they asked people who came in with acute relapses and said, how long have you had your symptoms before you called your healthcare provider, whoever it was, or before you went to the ER or whatever it was. What do you think the average was? I heard 2 weeks. That's pretty good. It was about 8 days. Yeah, so most people wait about a week with worsening symptoms before they say, okay, I'm having a relapse. So I'm not saying pick up the phone and call us or page us with every single new little thing that lasts only a couple of hours, but if it lasts more than 2 days, it's probably a relapse. The other thing you want to watch out for is there's something that triggered it. If it's a worsening symptom, an old symptom that comes back, it might be an infection. Do you have a cold or a flu or a urinary tract infection or something? You all know that can make old symptoms worse, but it shouldn't trigger a new relapse. All right, so we have symptoms that are there all the time, right, from the old attacks, and then we have MS relapses, which are sudden flare-ups or new symptoms that typically last several days, and they can be important to differentiate, obviously, because the treatment is very different. So typical symptoms, depending on their location, if it's the optic nerve, that's optic neuritis, and what we typically see is loss of vision in one eye. Now, a lot of times if somebody has an old episode of optic neuritis and they go out in the heat or exercise or something, their vision in that eye will become blurred again. That's called Uthoff's phenomenon, and that as long as it goes away again when you cool down, you're not doing any damage to the optic nerve. You don't need steroids. But if you get optic neuritis, new symptoms, say, in the other eye, or the vision suddenly gets worse and stays worse, then it may be a new relapse. Memory loss is a tough one, right? So some of the ones that come from the brain can be the most difficult. The brain stem can be relatively easy. Diplopia means double vision. Ataxia means incoordination. Slurred speech means slurred speech. So these come from the brain stem typically, and you may have had that type of symptom. Sometimes when you just have increased fatigue and memory trouble and stuff like that, that can be very difficult to decide whether that's actually new spots that are active in the brain or whether it's something that's old. So the best way to go about looking at that, if we don't see anything else when we examine you, is just to do the MRI scan. So sometimes people don't have a lot of very specific symptoms, but they have some increased memory problems and some fatigue and stuff. You do an MRI scan, and lo and behold, there are several active lesions on there. Okay, and you guys probably know about spinal cord symptoms. Those are the ones, spinal cord lesions or attacks. Those can cause some of the worst disability, right? So most of the time, weakness, numbness, pain, all that stuff comes from the spinal cord. Also the bladder problems, right? Going all the time, can't make it in time, up at night all the time. That all the bladder issues and bowel issues and all that, that's all spinal cord stuff. And then you can get, again, ataxia or incoordination, and you can get spasticity from the spinal cord as well, which is that feeling of tightness and pain in the muscles. So those are most of the symptoms. What do we look for when we're examining you? Well, the reflexes may be brisk. When we scratch on your toes, we're looking for a sign there. When we have you follow things, we're looking for whether or not your eye movements line up, because if they don't, that can cause double vision. Nystagmus is a common one, so when you look to one side, your vision might get jumpy, and we can see that when we examine you. Weakness, obviously, and then watching how patients walk. Very often, MS can affect walking, as you well know. So the medications for the symptoms are different from the medications for the relapses, which are different from the medications which prevent the disease from getting worse. So there are basically three types of treatment. I'm not going to go into all of the symptomatic treatments because that's a whole different talk in itself. So there are treatments for virtually all the symptoms of MS. The spasticity, we have muscle relaxants. The bladder problems, we have various agents to treat that. There are agents that treat the fatigue. It can be difficult to get them approved by the insurance company, but that's gotten a little bit easier lately because there are generic versions of drugs like modafinil or Provigil and so forth. And most of these are pain, of course, is treatable. Sometimes it can be difficult to treat. I wouldn't say everything is treatable. Tremor can be very difficult to treat, and the cognitive problems, memory problems from MS, are very difficult to treat as well. We don't have good drugs for that. But most of the others we do. Now, unfortunately, sometimes the side effects of the medications can be worse than the symptoms themselves. So the muscle relaxants in particular can make people more fatigued. So we have to be careful on the dosing there. The medications for the bladder dysfunction can give you dry mouth. They can make you more constipated and so forth. So sometimes you end up, same thing with the pain medications, making you more fatigued, and then you have to take something else for the fatigue. So we always want to try to maximize whatever we can do short of using more symptomatic medication. So that includes physical therapy, occupational therapy. Any kind of exercise that you can do is beneficial, stretching, yoga, anything, even if you can't really get out and walk very well. So we want to maximize all of that. We want to make sure people are sleeping all right. We want to make sure they're not depressed. If all those things are addressed, then there's a whole sort of cycle here of symptoms, and it can be a vicious circle. So I don't think you can read it from the back, but so if you just pick any one of these arrows, say fatigue, or say let's say start with say a bladder issue. So bladder problems keep you up at night, so you don't sleep well, so then you're more fatigued during the day, so then you take a nap, so then you're up at night, so then you have spasticity. Muscle relaxant makes you more fatigued during the day. You have to sleep during the day. You're up at night. There is this vicious circle in terms of the symptom management of MS, and a lot of them are related and interdependent. And depending on how bad the symptoms are, you can end up on a variety of different medications. Now, it's important to know that MS can't do everything. So it's not just once people get diagnosed with MS, you've all had this happen. You show up in the emergency room, you have a rash or a chest pain or something like this. They go, oh, it must be your MS. No. So you'd be surprised how little emergency room doctors and primary care physicians and stuff know about MS and what MS can do. It's almost like they think it's some sort of magic thing and it can produce any symptom whatsoever. That's not the case. MS, by and large, doesn't cause headaches. Now, you can have migraines and MS at the same time. That's very common. You can have sinus problems and MS at the same time. The one exception is trigeminal neuralgia, and if you've ever had that, that's a horrible headache. Usually it's in the teeth. It comes on with these horrible stabbing pains, and that can be from MS. But people think that because there's inflammation in the brain, it should cause headache. It doesn't. There are no pain receptors in the brain itself. There are only pain receptors on the coverings of the brain. So that's a common misperception. Syncope means passing out. MS does not make you pass out. If you're passing out, you probably either are having seizures or you're having a problem with your heart or your blood pressure. MS does not cause a rash. MS medications can cause a rash if you have an allergic reaction to them, so you have to take that seriously, but the MS doesn't cause a rash. By and large, MS doesn't usually cause swelling or edema. MS doesn't cause you to be short of breath or cause problems with your lungs or your heart, and so on and so forth. So don't just assume that it's your MS, and don't let the emergency room doctor tell you it must be your MS. Have them call the neurologist who's on call and discuss the case with him. On the other hand, there are some symptoms that are very, very common that sometimes can be MS, and I've seen it go the other way. So chest pain is one, or back pain or abdominal pain. So some of you might have had this MS hug, where you get this painful band-like sensation around the chest or the abdomen or the thorax or whatever. And I've seen people get huge workups for heart attacks and gallbladder taken out and all sorts of other things, when in fact it was the MS hug all along, and the emergency room doctor had never heard of that. So you have to be careful going the other way as well. All right, then let's talk about the treatment. So there are two other types of treatment. We have the treatment of acute relapses And then we have disease-modifying therapies, which are the therapies that are designed to prevent relapses and prevent disability in the first place. So we'll do relapses first. I won't spend too much longer on this. What this is showing is in the old days, before we could control relapses, when we didn't have disease-modifying therapies, what this shows is that the more relapses you had in the first few years, even the first 2 years to 5 years of MS, the more likely you were to have difficulty walking, 20 years later. So if you had more than 5 relapses right after the first 2 years of your diagnosis, about 80% of people were using a cane within 10 years. So it's not nearly that bad anymore. If you only had 1 relapse or 1 or 2, then it was 30 to 40 years out before most people were using a cane. And this is sort of the intermediate group. So this is all changed. This is all old studies called natural history studies, just looking at MS before we had any therapy, any disease-modifying treatments. So we know that over time, relapses lead to disability. So we want to prevent relapses. The relapse typical treatments, we really have the mainstay is IV solumedrol or IV steroids. And most of you, if you've ever had a relapse, have probably had IV steroids. And typically we do 3 days to 5 days in a row. And that usually is very effective in controlling the symptoms of the acute relapse. If you don't do anything after that, the symptoms can come back, so you need to get on a disease-modifying therapy to prevent new relapses. But the disease-modifying therapies, all the injections and Tysabri and all these drugs, they don't do anything for the acute relapse. They're all preventative, so you have to keep that in mind. If you're having an acute relapse, you have to come in and be treated with steroids, or sometimes we use this other steroid derivative. It's called Acthar. Some of you may have had that, or ACTH, which is adrenocorticotropic hormone. So what that is a natural steroid that your brain produces naturally that causes your glands your adrenal glands above your kidneys to produce a natural steroid. So that can be given at home. The problem is the cost. So it's becoming more available. Solumedrol is very cheap and easy, but you have to come in and get it intravenously. Acthar, on the other hand, is very expensive. Solumedrol sometimes causes side effects, so your blood sugar can go up. If you take it long term, you can get osteoporosis, diabetes, cataracts, glaucoma. We don't use it so much like that anymore. Before we had these modern treatments, we used to have people come in every month and get a dose of solumedrol, if you can imagine. So their osteoporosis would get very bad. They'd get diabetes, they'd get glaucoma, they'd get cataracts, but for some people it was worth it because it prevented their MS from getting worse. So steroids work very well on inflammation. The problem is the side effects. With Acthar, which you can take at home, you don't have to come in and get it intravenously. As I mentioned, it's secreted by the pituitary gland naturally. Problem here is it's very expensive, although it's getting a little bit easier to get approved, and it doesn't have as many side effects as the solumedrol. So the only issue there really is the cost and getting the insurance company to pay for it. So we usually don't use Acthar unless people are having a lot of side effects with the solumedrol, the intravenous treatment, or if they have some reason they can't take it, like they have really bad diabetes or particularly bad osteoporosis, and we're worried about them having a hip fracture. All right, any questions on relapses and treatment of relapses? I see food still coming out, people still eating, so that's a good sign. All right. So I'll go now into the treatments, the disease-modifying therapies. So here's the landscape now. I told you 20 years ago we didn't have any FDA-approved treatments for MS. All we had was steroids and ACTH, and sometimes we gave chemotherapy and other drugs on an experimental basis to try to prevent MS from getting worse. So now we have whatever's up here, 13 I think approved now, and then others in the pipeline. So we talk about a pipeline of drug development. So the first one was beta-seron to get approved, then we had Copaxone and Rebif and Avonex, and Tysabri came out in 2005. As you know, It was off the market for a few months, and then it came back. And then we've had various other oral drugs just in the past 5 years. So the first one was fingolimod or Gilenya, which is here. Extavia is the same as beta-seron, so that doesn't really count. Then we had Aubagio or teriflunomide. It's been out for about 3 years now. And Tecfidera, which has been out a little over 2 years. Then we have some newer ones here. We got a new version of Copaxone, right? So Copaxone became 3 times a week. There's a long-acting Avonex here called Plegridy. And then the newest one on the scene, there's a generic Copaxone, but the newest one also is the Lemtrada. Other ones that are in development that look very, very promising are these. Ocrelizumab. I just got back from a conference in Barcelona last week where they had the initial data on ocrelizumab, and it looks very, very promising. This is a drug called Daclizumab, which will probably get approved next year, and that's an injection at home once a month. The ocrelizumab will only be every 6 months, and then the ofatumumab will be either an intravenous infusion or a at-home subcutaneous injection as well. This one's not quite as far along as the ocrelizumab. So that's sort of the landscape, and then if you go out further, there are, of course, lots of drugs that are not quite as far along in development. But these are the ones that are almost certainly going to get approved within the next few years. And everything to the left of this line has already been approved as of 2015. Okay, so many of you may have started on an injectable treatment. Here they are. I'm not going to go through them all in detail. We had beta-seron. That came out in 1993. Subcutaneous or under the skin every other day. Copaxone came out. It was every day under the skin. And Avonex came out. Longer needle. You had to get it into the muscle, but it was only once a week. And then Rebif had already been approved in Canada and Europe, but didn't get approved in the United States until 2002. So we only had 4 treatments for a number of years, but they were all safe. They were all effective. There were no serious safety concerns. So here's the neurologist up here. He's got a drink on his stomach. He's snoozing away because nobody had any significant safety concern. Nobody died from these drugs or got terrible infections, but they didn't work all that well. They were okay. They work better if you started them early on. So CIS, I talked about earlier, that means clinically isolated syndrome. So I won't go through the numbers, but the point of the slide is to show that if you start the drugs, these are the same drugs now, if you start them at the time of the first MS attack rather than waiting for the second MS attack, you can see that these numbers are higher. They reduce the likelihood of the MS coming back by almost 50% instead of 30%. So the earlier you can start on medication, the better you're going to do overall. Then, you can't read it up here, but it says Trouble in Paradise. So then we had, first Novantrone came out, which looked like a very promising drug at first, but it ended up that it caused problems with the heart, congestive heart failure, and then lately we've been seeing some cases of leukemia, unfortunately, turning up with Novantrone. And then in 2005, natalizumab came out. So with natalizumab, we know how it works. It attaches to this T cell and it prevents it from getting out of the bloodstream and into the brain. It works very well. So now we're up to a 67% reduction in the relapses. What are the problems? Some people get an infusion problem, reaction to it, and sometimes we have to stop it. And that's usually because they develop antibodies against it. We have to check the liver, but that's no big deal. But the big one is this infection, PML, or progressive multifocal leukoencephalopathy. So there are 3 things that you need to cause PML. First of all, there's a virus that causes it specifically. So if you don't have the virus in your system, you can't get it, but most people have the virus. If you've received any prior chemotherapy or immunosuppressant drug, that increases the risk. And then once you've been on the drug more than about 2 years, if you have the virus in your system, the risk goes up. So that shows this. This is the first year. Second year, almost nobody gets the infection. Then as you get into the 3rd, 4th, and 5th years, if you have the virus in your system, the risk goes up. But it doesn't keep going up continuously, so it seems to level off here after about 5 years. So we can test you now with a blood test to see if you have antibodies against the virus. If you don't have antibodies at all, then the drug is basically safe as long as the antibody test stays negative. The risk of getting the brain infection is about 1 in 10,000 with a negative antibody test. On the other hand, if you have anything above that, if you have detectable antibody, the risk goes up. It's still pretty low in the first year, here about 1 in 10,000, but if the antibody level is greater than 1.5, then that goes up to 1 in 1,000, and so forth. So we have to stratify the risk based on the antibody test. So Tysabri is a very effective drug, more effective than the injections and more effective than the pills, but it carries this risk of brain infection, which can be worse than having MS. So it's a very good drug for people who don't have this JC virus. If you do have the JC virus, doesn't mean you can't take it, but the risk is higher after about 2 years. And then the other medications that have come out recently, you've got 3 oral agents. The Gilenya has been out about 5 years, the Aubagio a little over 3, the Tecfidera a little over 2, and then the most recent is the Lemtrada. So I won't spend a lot of time on the clinical trial data, just in interest of time. The issue with the fingolimod, as you probably know, is that it slows your heart rate with the first dose, so you have to come in and be monitored for 6 hours, and you have to have eye exams before you start it, and once you've been on it about 3-4 months. But after that period is over, it tends to be very well tolerated, no significant side effects. It works very well, not quite as well as the Tysabri, but almost. And they've only seen 3 cases of the brain infection on fingolimod. So that's less than 1 in 10,000 overall for people who've been on it about 2 years. I won't go through these. Then teriflunomide or Aubagio came out, and that's not quite as effective, but pretty good. Reduces the risk of the relapses, again, by over 30%. So a little better than the injection drugs. And then the only issue here, unfortunately, it's in a pregnancy category X. So even though it may or may not cause pregnancy problems in humans, it does in animals. So if you do want to get pregnant after you've taken this drug, you have to wash it out of your system. And that can take a little while, and that's a problem. Otherwise, it tends not to have a lot of side effects. Some people get a little bit of hair thinning. Sometimes the liver enzymes go up, so you have to have your blood checked once a month for the first 6 months. So that's the Aubagio or teriflunomide. And then the other one, the most recent one is Tecfidera or dimethyl fumarate. Some of you may have taken this. This one you have to take twice a day, and it can cause some flushing side effects and some nausea and some diarrhea, usually for the first 2 weeks or so. But then after that, that tends to go away. The only thing with the Tecfidera is now we're seeing that after people have been on it for 9 months to a year, sometimes their lymphocyte counts, their white blood cell counts start to go down. So it's very important now to get your white blood cells, your lymphocytes checked if you're on Tecfidera. About every 3 months or so, you should be getting those checked. And that was not something that we initially did when it first came out because we didn't know about that. And then finally, of the antibodies, I already talked about Tysabri. The new one is Lemtrada or alemtuzumab, and then these are the other ones that are in development. I won't touch on rituximab except to say that it works very well, and the new drug called ocrelizumab works the same way. So these are MRI activity, and when you give this drug, it goes down essentially to 0. So this is very, very promising, and the results last week were similar. So if you get this, when this ocrelizumab gets approved, you'll come in, you'll get 2 infusions 2 weeks apart, and then every 6 months after that, and basically it pretty much shuts the MS down. So it looks very good. Hopefully there won't be any significant safety issues with it. And then the alemtuzumab works very well as well. Here are the clinical trial results. And the issue with this, you come in for 5 days in a row, and you get it intravenously. You can have some infusion reactions. You can see that it suppresses the disease activity very well. And then these are the disability scores. So this is the only drug so far where we've seen when the disability score goes down like that, that means the patients are actually getting better. So most of the drug, here are the drug, these patients are on Rebif, these patients are getting the alemtuzumab. So the Rebif patients over the course of in this case, 4 years, got a little bit worse. but the alemtuzumab patients actually got better, a little bit better. So that's very promising. The issue with that drug, unfortunately, is there are a lot of autoimmune reactions to it. So you can have thyroid problems quite frequently, about 30% or so. And then there is a rare bleeding problem in about 1 to 2%, and some kidney problems in less than 1%. So once you get this drug, you have to have your blood and your urine checked every month for 4 years after it, because they've seen these complications out to as long as 4 years after the drug. So very, very effective, but has a very serious what they call a risk management program, where you have to follow up with a blood test and stuff. So that's pretty much where we are. I'll stop there. I won't. I think we're getting into an area of therapy now where we have to consider risk more and more carefully. The drugs work very well now. We've got a lot of drugs that basically can stop relapsing remitting MS. As I said, the big unmet need is the secondary progressive MS. We need drugs that will reverse disability, that will make people better. We don't have those yet. They're on the horizon, as I mentioned. But the better the drugs get, the more the risk is. The risk of infection, the risk of other autoimmune diseases, in the case of the mitoxantrone, even the risk of cancer. So we have to be very, very careful the way we use these drugs. And that's true in other areas as too, oncology, rheumatology, and so forth. So we're using these drugs over a long period of time, sometimes a lifetime. So we don't know sometimes when we start out what the long-term risks are going to be. Okay, so in summary, we talked about the cause of MS as an autoimmune disease, the 3 types of treatment affecting acute relapses, the disease-modifying treatments which prevent relapses, and then symptomatic treatment. The acute therapies are aimed to get people back to normal or back to baseline for a relapse, whereas the DMTs, or disease-modifying therapies, are designed to prevent relapses in the first place. And then the symptomatic treatments just affect the symptoms. They don't affect the disease itself. So 3 different areas of treatment. And then finally, if that's not enough, I know you probably can't read it, but it says there is one more symptomatic treatment, Mr. Reynolds. I personally scored some very good weed, and maybe that'll help with your symptomatic treatment. So, okay. Any questions?
Thank you, Dr. Buckle. We have questions for Dr. Buckle. We have 15 minutes for questions. I have a question here. Speak right into the microphone.
Yeah, I was taking Tisabri, and I'm now taking Rituxan, and I'm looking at Lemtrada. With the Tisabri, I was told I couldn't get live virus vaccines, like for shingles, for instance. Is that true with the Rituxan and the Lemtrada?
So there are 2 issues. One is, so the question was, can you get vaccination, live vaccines, while you're on these drugs? So in particular, Tisabri and Rituxan. And the same is true for the Gilenya. There are 2 issues. Number one is, if you're on the drug, the vaccine won't work as well. So all these drugs suppress the immune system to a certain extent, so that also means they'll suppress the reaction, your immune system reaction to the vaccination. So it's best to get vaccinated before you go on any of these drugs. The Tisabri is out of your system within about 3 months. So if you're going to get vaccinated in between Tisabri and Rituxan, I would suggest that you do it before you start the Rituxan, and ideally you would want to give it about a month for the vaccine to work before you start on the Rituxan. But you can get it. There's a whole literature on this issue of whether people with MS should get live vaccines. Obviously, you would like to avoid it, but the bulk of the literature shows that they're actually safe, and you can get a shingles vaccine even if you have MS.
Okay. Any other questions? I saw lots of hands. Wait, you got to wait for me to come over. Come over. You have a question?
Oh. Dr. Buckle, is there a connection between some of these new drugs and chemotherapy drugs? That name Rituxan sounds very, very familiar to me.
Yeah, good question. So Rituxan is used to treat leukemia and lymphoma, particularly B-cell leukemia. So it works on a molecule called CD20, which is on B cells. So it selectively kills B cells, so they use it in lymphoma where the B cell counts are very high. We're using much lower doses here to treat MS, but you're right, it is used as a chemotherapy agent. And a lot of these new drugs were initially used in cancer and then found to be effective in autoimmune diseases as well, such as MS, rheumatoid arthritis, lupus, and so forth. So there is some crossover between the fields.
My question is related to PML and the JC virus? JC virus. Okay. You were stating that if you test negative or you didn't show that you had JC virus, the JC virus, are there any chances of you developing the PML? Can you go over that again?
So is there any chance? Yes. Theoretically, the chance of getting PML, if the test is completely negative, is about 1 in 10,000, which is pretty good odds, as long as the test remains negative. So if it's negative, we just repeat it every so often. If you've been on the drug more than 2 years, we like to repeat it about every 3 months or so to make sure it doesn't turn positive. If it turns positive, you might want to come off. You don't have to, but the risk is higher if you come off. Other than that, it all depends on the number. So that little risk table I showed you very quickly, that's what we go by typically. And so depending on the number, we can tell you what your risk is. It can go anywhere from 1 in 10,000 up to almost 1 in 100 if you've been on the drug for more than 2 years and you have a very high JC virus antibody index or titer. So it's complicated.
I have a question here.
If you test positive for that JC virus, can you take Lemtrada?
Yeah, that's a good question too. So if you're positive for the JC virus, can you take Lemtrada? Yes, you can. We don't know what the risk of getting PML is on Lemtrada. The only cases of PML on Lemtrada that we've seen have been, again, in patients with cancer. So again, this is another antibody drug that was initially used to treat cancer, typically lymphoma. So patients with cancer, unfortunately, are typically on multiple drugs at the same time. So they're not just on Lemtrada or alemtuzumab, they're on a variety of other things as well. So it's almost impossible to tell which drug caused the PML, the brain infection. So we haven't seen it in patients with MS so far. Doesn't mean it couldn't happen, but we haven't seen it so far.
Okay, we have a question here.
Because MS has a cognitive issue, is there any correlation between MS and its cognitive issues with Alzheimer's?
Yeah, so the short answer is no, although it's hard to say that when you're faced with someone who's having cognitive issues, but the cognitive issues are different in MS, and the pathology is very different. So in Alzheimer's disease, Alzheimer's is a neurodegenerative disease where you see a different pathology under the microscope in the brain. And it's only certain areas of the brain are typically affected by Alzheimer's disease. Typically, people with Alzheimer's disease don't know that they're losing their memory except very early on, whereas MS, it's the opposite. As you probably are aware, most people with MS have a different type of cognitive dysfunction. The chief thing is what's called difficulty with executive function, and that's typically like multitasking, short-term memory. What I always ask people is if they're doing their email or working on the computer, somebody comes in the room or the phone rings, they answer the phone, they get back to their email. Can they pick up right where they left off, or do they have to start all over again? That's the kind of thing you usually see with MS. In Alzheimer's disease, especially as it gets more advanced, the patient with Alzheimer's disease often doesn't even know that he or she is losing their memory, or that they're disoriented, or that they have other problems. So that they're very different is the bottom line.
Do we have more questions?
On the doctor's TV show, they said that MS was being treated quite well with fecal infusion therapy. Have you heard of it?
Yeah, I have heard of it. I'm not familiar with it's not quite as horrible as it sounds. First of all, so the idea is the microbiome. So you have trillions and trillions of bacteria in your gut, and they influence your immune system. They're called commensal. So your immune system is always reacting against the bacteria in your gut, your colon in particular, and vice versa. The bacteria in the gut are responding against your immune system. So even if you take an antibiotic or something, it vastly changes all the bacteria in your colon. So for a number of autoimmune diseases, they've tried this where they eliminate with high doses of antibiotics all the bacteria that you're carrying in your gut, and then they do, believe it or not, what's called a stool transplant. So they don't put it down your mouth, don't worry. They go in with an endoscope and they put new stool in your gut, and then it repopulates the gut with new bacteria, and you get a new immune response. It works in inflammatory bowel disease, Crohn's disease, ulcerative colitis. It's been shown in some small trials to work as you might expect it to work. It has not been shown conclusively to work in MS. It may. We don't have the trials to show it.
When are they coming? When are the trials coming?
They're coming now. So the easier way to look at this, as you can imagine, would be to do a trial with probiotics. So there are a number of people that are looking at probiotics, doing placebo-controlled trials to see if changing the gut flora or the microbiome will influence the immune system, the cells in the blood. So a number of different groups, including the group I used to work with in Boston, are doing trials of that.
Okay, my question was, with the live viruses,
Yes.
such as the shingle shot
Yes.
and the facsimiles thereof, are they possibly going to cause an exacerbation?
So probably not. So this always comes up. They've done a lot of large-scale studies on this, and it's a very hard thing to study. But the basic, if you can avoid a true live virus, you should. The ones that are that have the highest evidence for perhaps triggering a relapse of MS are number one, I think it's yellow fever, which is not something you're likely to encounter or need a vaccine for. And number two, you can take flu vaccine. That's not a live virus, but flu mist, which is the one that they give children that they inhale through their nostrils. That's a live virus. So you want to avoid that, or if your child had flu mist, you want to stay away from the child for at least a few days to a week, or not get that mucus. But all the other ones, including the shingles vaccine, have never been shown to cause an MS exacerbation. So we give shingles vaccine all the time in people with MS. And in fact, you're much better off getting the shingles vaccine because you don't want to get shingles. When you suppress the immune system with these drugs, you're at higher risk to get shingles. And it can be particularly bad and particularly painful. So the risk of a relapse is very, very low.
Okay, we're going to do the last question over here.
Have they come up with anything for neuropathic pain?
You mean anything new? So the question is about neuropathic.
Anything that works?
Anything that works. Yeah. I mean, there are drugs that work for some people, but there are some people where none of the drugs work, and I understand what you're saying. So there are some drugs that they have in Europe, and I believe in Canada, actually, that are based on cannabis, marijuana, like Sativex and things like that appear to work in neuropathic pain. They haven't been approved here because of political issues and so forth. We have this cannabis oil now and stuff in Georgia, although I'm not sure how well that works. I haven't heard that it works particularly well from the people who have tried it. And there are several new compounds for neuropathic pain. There's one that's in clinical trials now actually to treat MS, not just pain. They use it, it's called, now I'm blanking on it because it's in a clinical trial for progressive MS, but it's used in Japan to treat neuropathic pain as well. The trial's called Sprint MS, but I believe it's fully enrolled. So there are a number of experimental agents for neuropathic pain. I can't think of anything really new lately, since Lyrica and Cymbalta and the old standard ones have been around for a long time.
All right. Well, great. Thank you very much.
All right, so we'll turn it over.
Thank you. One small point that Dr. Buckle brought up, because he gave us a lot of incredible information. But tonight I'm going to talk to you about mood disruption and cognition. And we're going to look at different coping mechanisms and how we handle this, and how this impacts not only the person living with it, but the people around us. So researchers, physicians, their literature recognizes that approximately half of MS population will experience some type of change in cognitive functioning through the course of their disease. Okay? You may have experienced this, you may not have. And I wanted to go over the definition of cognition, because I've learned this back in my training, but I found it to be a little complicated, and I really wanted to review it with you all so you really understand exactly what we're talking about when we talk about cognition. Okay? Cognition refers to a group of mental processes such as information processing, language, memory, visual perception and special skills, calculation skills, and executive functioning, as Dr. Buckle mentioned. And that's a lot of different things. So I really want to kind of go over exactly what each one of those means and make that an easier definition for you. So when you look at information processing skills, what is that? Okay, so that's the ability to focus, to maintain your focus, and then shift attention from one thing to the next without losing track of what was going on before. Okay? This also includes managing and incoming information quickly. So as Dr. Buckle mentioned, if you're doing emails and then you get a phone call and then someone's at your door and then you go back to your email and you just can't reconnect with what you're doing, you know, that could be something that's affecting your information processing skills. And again, you also, a lot of times there's a tendency to say, well, you know, is this my MS or is this also just my normal aging process? And, you know, we get, you know, tired and we have memory issues. So it's really something that you need to look at in terms of how much it's impacting your life on a daily basis. And if you notice it, if your family and loved ones notice it, then it may be definitely worth discussing with your neurologist. So memory, okay, a complex set of skills that includes learning, storage of information, and the ability to retrieve that information on command as needed. So this is also one of the most common symptoms when you look at the cognition impacts with the disease process in MS. So again, you know, people, you can see somebody and you'll say, oh, you know, oh, I remember, you remember who they are, but you know, you can't remember their name. It happens. It happens to people without MS. It happens with MS. But when it becomes, you know, a constant issue where you're looking at your phone and you can't recall the word for phone, that's more when you're looking at a memory and cognition kind of issue. Okay. And language, the ability to understand and use language appropriately in daily situations. And we've all had that, you may have had that loss of words where you just can't draw on the word that you're looking for. You know what you want to say, but it's just difficult to draw on that word. Visual perception and special skills, okay? This, again, when I talked about you're looking at your phone and you know it's called a phone, but allowing yourself, having the ability to recognize an object. I have many patients that talk to me about changes in their handwriting, draw or write, putting things together and assembling things. And I know IKEA's directions are very hard, but you know that's for everyone as well. But you know, and also finding your way around, knowing that you're on this road and you've been on this road 1,000 times, but you're just having trouble knowing where you are, even though you know you've been there before, is also something to do with visual and special skills. And then executive functioning. This allows us to get through a day by overseeing and coordinating tasks, like the ability to organize your day, what you want to do during that day, and completing those things. The ability to plan, problem solving, judgment, how you make decisions, and what influences you, and reasoning. And then the ability to monitor your own behavior. And this is something you may have insight to, or it may be pointed out to also to you by family members or friends, a change in how your behavior appears, or some decisions that they were surprised you made. So something to be aware of. And again, as Dr. Buckle said, most likely if you're experiencing these things, you're able to recognize these things. So what do we do? Coping strategies, okay? There are different things, and again, if you're experiencing any of this, I recommend that you see your neurologist, and also to get referrals to get neuropsych testing. That's something that is definitely most likely covered under your insurance, and something that could really evaluate these things in more detail. But some things that an occupational therapist may recommend is to speak out loud, more preferably in the home, but to remind yourself, when you're unplugging your iron, to actually say it out loud. I am unplugging the iron, and make it a pattern. So when you get in your car and you're halfway down the street, how many of us have had to turn around and say, oh my goodness, did I unplug the iron? It's suggested that if you actually make the verbal, conscious announcement to yourself that you are unplugging that iron, or whatever action you want to remember, that it can help. Okay, so planning your route and your itinerary for the day before you head out. The ability to focus and stay on track, or on the right path of what you wanted to do today, can be swayed if you're struggling with focus or with attention. So if you have a notepad and you have what you want to get done on Monday and you write it down, you can take that notepad with you and say, I am going to Target this morning, and then I'm going to the veterinarian, and you can follow your notes for the day. And also, this is interesting because I have a lot of patients that just struggle with daily tasks within the home, where they have a lot of goals that they set for the day, but they don't get it done because they kind of get distracted and get consumed with one other thing. So to keep like a fanny pack, or to keep an apron on while you're in the house, and actually keep your notes on you. Because even if you write in that notebook, if you leave the notebook on the bedside table and you never reference it again that day, and it's not physically on you, it's not that useful. So to actually keep it on you in the house while you're working, or while you're out and about, keep your list at hand so that you know exactly what your plans are for that day. And reminders, again, to keep reminders in your to-do list and your designated book. And also to use your mobile device. If you're tech savvy and you're comfortable using your cell phone for reminders, set reminders. Have them alarms going off all day. If you need to leave at a certain time, set your alarm. And you can also leave yourself voicemail messages. And also during cooking, to set the timer so that you don't forget that you put something on the stove. And consider choices that you make to make things easier for yourself, and try not to overtask yourself, because there's many people that you can look back and say, well, 10 years ago I used to go to the gym, and then I would go to do all my shopping, I would work, and then I would cook dinner. When you overtask yourself, it often is a burden and could impair or make you feel more overloaded or stressed. So actions to take: compliance with a disease-modifying therapy. If you do use a disease-modifying therapy, obviously literature and evidence supports that less new lesions and new lesion activity equal less cognitive impairment. So using a disease-modifying therapy can control this, has been proven that, as Dr. Buckle showed us. Cognitive testing and cognitive rehabilitation, where they can actually teach you some of the skills that I was mentioning. If it's really affecting your daily life, they will work with you and teach you how to adapt to these issues. Memory medications and supplements, definitely something to discuss with your physician. And I really think that it's very important that if this is something that's impacting you, that you need to make a specific appointment with your neurologist to discuss this specific topic, because it's so common when you get to your neurologist appointment that you have so many other issues that one may not get discussed, because you end up speaking about your spasticity and maybe you're having sleep issues, and then your cognitive issues may not be touched upon during that appointment. So this whole subject is really worth a doctor's visit if it's something that means a lot to you and that you want to address. And remember to address fatigue, which I think was very interesting, because sometimes untreated fatigue could impact memory issues as well and impact cognition. So it really makes sense. I mean, the more fatigued you are and the more tired you are, the more impacts it could have on your executive functioning and your ability to think clearly. So there are some people and some patients that I've worked with who've actually treated their fatigue, and then the other issues did get better. So it was more fatigue related than cognitive related. And Dr. Buckle had mentioned that there's, of course, different drugs to treat fatigue. You can look at it through pharmacological or non-pharmacological ways. Very good news that Dr. Buckle said that modafinil or Provigil has a generic. That's great. I just learned that tonight. That's wonderful news. And again, to speak to an occupational therapist who's skilled to work with you on these issues. And stress and factors that increase symptoms. I really encourage you to try to live with a heightened awareness of what really triggers your symptoms and what makes you really feel bad. What makes your symptoms get worse? If stress is one of them, of course we can't control our environment. Stress happens every day, but we can work on how we control how we respond to stress. And that's where you see a great impact on your health. And so how do we do that? It's a daily practice. It's not something that comes naturally. You want to look at things like yoga, like meditation, like mindfulness practice. A lot of these things are really popping up in the communities, very inexpensive. You can seek them out and kind of learn to have more of a presence of your stress response, so that triggers that make your symptoms worse don't get impacted as much. Okay. So I'm putting some questions out there for you. I'm going to wrap it up really quick, but I want to hear your questions if you have any. But just for some thought for you, self-assessment. So if you think to yourself, have you noticed cognitive issues? Is this something that you think is impacting your life enough to discuss with your physician? And again, to make note of what things may help, what things may make it worse, and what things are your triggers. Do you notice that after an 8-hour night's sleep that you're kind of functioning a little bit better? Maybe you notice it doesn't make a difference at all. But to try to make note and even jot them down. When do you feel you have better days versus not as good days? And what do you do to help yourself? How do you cope? How do you manage this? And how do you feel when you have an MS moment, as we say, in front of other people? I often see people beating themselves up, like they're hitting themselves over the head with something, because they're saying, "Oh, I feel so stupid. I'm so frustrated," because they lost track of a conversation. But rather than beating yourself up, to try to accept where you are that day, and you're having a cloudy day, and possibly explain to the person, can we go back on what we were talking about, rather than being hard on yourself. So how you treat yourself regarding this issue. And also what steps you can take today to address your symptoms. And again, I do encourage you all to not ignore this, as it's a legitimate symptom, and it's something that can be helped. And I wish you the best with it if it is having an impact on you and your family's lives. Thank you guys. Have a great night.